All right, so sound off in comments. What are you drinking for tea today? Wendy said she has her cup of Earl Grey, 1 sugar, and a dash of vanilla almond milk. That sounds good. I am drinking just water because it's really hot in here, but I have a cute mug. All right, we have a few more people joining us. All right, so we're going to go ahead and get started. I'll keep letting people into the room as they continue to join us. Thank you so much, Heather, for joining us today. We are super excited to have you. I'm going to go ahead and introduce Heather, although I'm sure she needs no introduction at all. Heather is a gem in the endometriosis community. She is one of the most dedicated, fiercest warrior queens of endo advocacy, and we are thrilled and very privileged to have her joining us today to talk about the power of patient advocacy. Heather Guidone is the Surgical Program Director for the Center of Endometriosis Care in Atlanta, Georgia. She is focused on bench to beltway to bedside efforts in endometriosis research, education, policy reform, patient-centered care, and more for almost 30 years. Most importantly, Heather has also struggled with the disease herself, as well as struggled with infertility. This brings a unique perspective to her professional efforts. She volunteers her time in many different areas, collaborating as an executive board member, advisor, editorial board member, speaker, advocate, research grant reviewer, and more. She has contributed to countless books, articles, and publications on endometriosis, pelvic pain, and women's health, including most recently the landmark academic book, The Pelgrave Handbook of Critical Menstruation Studies. If you haven't had a chance to check out her chapter, I definitely recommend that you do. It's an excellent, informative read. She remains engaged as a member of several professional organizations, including the American Public Health Association, Society for Menstrual Cycle Research, and many others. As a board-certified patient advocate and disease educator, her focus remains on reducing diagnostic delays and fighting for access to early and effective treatment for all. So thank you so much, Heather, for joining us today. For those who didn't hear when we started, make sure you stick around till the end. We'll have an opportunity to ask some questions. And then Maria, who is the chairwoman for the Endometriosis Foundation of Houston, will be helping us with a t-shirt giveaway. So at that, Heather, I'm going to go ahead and turn it over to you.
Thank you so much, everybody. I really appreciate you spending your Saturday morning, evening, afternoon, wherever you are with us today. You know, this is obviously a topic near and dear to all of our hearts. So I'm just going to dig right in and attempt to share my screen. Let's hope that it works. Okay, so move myself out of the way here. All right, so endometriosis and advocacy, right? That's why we're all here. And I want to just thank everybody at EF Houston for all of the work that you do, and of course, just for letting me be here today. And of course, to my fearless leader, Dr. Ken Sonervo, and our CEC team. You will not find a harder working advocate team anywhere. And yes, I'm biased, but it's also true. Standard disclaimers, disclosures apply. I have no disclosures. Standard disclaimer, nothing that you hear today is medical advice or directive. I also always include a statement of inclusivity, as it's very important to represent all stakeholders in endometriosis. Not everyone with this disease identifies as female. So it's really important to recognize and include, everyone who is struggling with endometriosis, whether or not they have a uterus, how they identify, whether or not they menstruate. So anytime women is referenced herein, such as referential citations, that's really just a framework meant to incorporate all bodies who are dealing with pelvic pain gynepathologies like endometriosis. So jumping right in, health advocacy. As you see here on the quote, in the medical profession, activities related to ensuring access to care, navigating the system, mobilizing resources, addressing health inequities, influencing health policy, and importantly, creating system change are known as health advocacy. So we ask ourselves, does advocacy really matter in endometriosis? 1000%. Patients are not just the objects of change brought about by advocacy, but they are also the drivers. When we want to see something done in endometriosis, more often than not, we have to do it ourselves. Those of you who have been around a long time like me, you know how that works. Sometimes you have to create a seat at the table for yourself. So why we advocate? To influence healthcare activism and policy. That basically means working with government, legislators, national health ministries, insurance companies, and within the medical system to address concerns about quality of our care, access to care, which is so critical for so many of us, cost of that care, whether we have insurance, whether we're underinsured. All of these factors really influence and can diminish, unfortunately, care seeking. We also advocate to shape research. That means really representing the patient voice in research, whether it's clinical trial design, serving as a watchdog to see if there are issues that need to be addressed, and really striving for meaningful and translational research. And that means things that impact us in the here and now. Unfortunately, as we all know, endometriosis is one of the most underfunded and under-researched diseases, and we're going to talk about that a little bit. We advocate to confront disparities, socioeconomic, racial, ethnic, other disparities, which also diminish care seeking and which are unfortunately very persistent in the OBGYN medical industrial complex. And of course, to raise awareness. Everyone here is probably doing their very best, I'm sure, to advocate every day in your own ways. I know that you're out there on the socials. I know you're in the communities, raising awareness, educating, and correcting this information. Health literacy really matters. It connects us to better care, and representation matters. We want to see ourselves in the materials that are being put out about endometriosis, and of course, to improve care. That's the most important thing, right? So advocacy really does drive meaningful changes. They are patient advocacy and health equity really go hand in hand. They're very both catalysts of change. And again, as I said, patients are not just the objects of change, we drive the change. Raising public awareness helps make a difference in the legislative sphere, in the support resources we have accessible to us, in terms of funding and engagement. And, it can't be performative advocacy. When I say nothing about us without us, I mean it. We need a seat at that table. So we need to be present wherever decisions are being made about our care and treatment. And advocacy enhances patient experiences and outcomes. It helps us as patients. It helps other patients in the community really connect to the right team for the right reasons. And, endometriosis is not a disease of just a lesion. It's a systemic illness. So we really need to approach it from a multidisciplinary perspective. So we need to promote that big picture approach. And that means bringing in, all the specialists who are focused on working towards getting that patient better. So we can't talk about advocacy without talking about why it matters. So we're going to talk a little bit about endometriosis. I'm not going to go too deep. We're going to stay a little topical today, but we do need to review some facts and figures and so forth so that we can understand the scope of the problem and why advocacy matters so much and why it is so critical. Clinically speaking, endometriosis is a systemic inflammatory disease characterized by endometrial-like tissue in extrauterine sites. And what does that mean, endometrial-like? So the tissue is somewhat similar to the native endometrium, but they are not identical. There are a lot of differential properties between the two. And you will hear us talk about this at the CEC endlessly. Diagnosis is required. Histopathological diagnosis requires the presence of at least two of the following: epithelium, gland, stroma, and or hemosiderin-filled macrophages. That is how they arrive at the diagnosis, and that's done through surgical biopsy. You can diagnose, quote unquote, the disease based on things like imaging and symptoms and so forth, but that's not considered confirmative. What happens with endometriosis is you have a sustained inflammatory response, things like laying down new blood cells, adhesions, fibrosis, scarring, local infiltration into the tissue, pain, symptoms, things we all know really well about. Endometriosis is the most common cause of chronic pelvic pain. And although we talk about it as a gynecologic disease quite frequently, it's really, really important to note that extrapelvic disease is reported in a considerable number of cases. You do not need a uterus to suffer from endometriosis. The disease has been diagnosed in postmenopausal cases, after hysterectomy, after taking out the ovaries, in those who have never menstruated, in fetal autopsy, and even in some males. What causes the disease remains an endless matter of debate. Things like stem cells, defective embryogenesis, dysfunctional immune response. The most popular one, of course, being Sampson's theory of retrograde menstruation, which has really not borne out to be factual because there are other factors that are involved. If everybody who had a period, basically 90% of people who have periods have retrograde menstruation, which is what Sampson's theory is. Only 10% will develop endometriosis. So that's not the final answer. In all likelihood, there are a lot of different factors probably combined. A lot of research points to the fact that we may be born with it and it's later triggered through a number of different factors. There are three distinct entities. I don't like to focus on this too much because it doesn't really elucidate the full nature of the disease, and it kind of cuts out extrapelvic disease. But typically speaking, there's peritoneal, ovarian, and deeply fibrotic disease. Folks think that they have different origins, and generally, where the endometriosis is at the time of surgery is generally where you will see it at the next surgery if it's not removed. It doesn't typically spread like daisies in a field or poppies, but it certainly does progress in terms of symptoms. It can become more fibrotic, more deeply invasive. And again, when I say this is not just a disease of a lesion, this is really a systemic disorder. There are many comorbidities and a lot of adverse impacts associated with endometriosis. Systemic inflammation, formation of endometriomas, which, as most of you will know, are the sizable ovarian cysts filled with menstrual debris and blood, adhesions, distortion of your organs. It is the third leading cause of gynecologic hospitalization in the United States. When we talk about comorbidities, a lot of current research shows things like certain autoimmune diseases, allergies, asthma, other gynecopathologies like adenomyosis and fibroids, chronic fatigue, real popular. I know for me, I still struggle with that. Even more recently, rheumatoid arthritis, certain cancers, although the risk is very, very low, and even coronary heart disease, which was surprising. And that really needs to be teased out more to see exactly what that relationship is. Of course, everybody knows endometriosis is associated with infertility and pregnancy loss. What is not always frequently talked about or the adverse outcomes associated with endometriosis in pregnancy. Things like intraperitoneal bleeding, pregnancy-induced hypertension, preeclampsia, placenta previa, things like that. So again, this is not simply, a pelvic disease of menstruation. This is a systemic disease with a lot of impact. It has a very complex relationship with chronic pain, which we still don't know about. Things like nerve fibers, pro-inflammatory stimulation, and certain biological mechanisms are thought to be tied to the chronic pain aspect of endometriosis. We do know that in those with specifically endometriosis-related chronic pelvic pain and infertility, we know there's a much less quality of life in those affected, as well as an increased risk of not only physical morbidities, but psychologic as well when we compare them to people without endometriosis. There's research indicating that changes in the actual brain are reported in terms of brain chemistry and functioning in the pain processing regions. And that's interesting because it's very specific to endometriosis patients with chronic pelvic pain, but not asymptomatic patients with endometriosis. So that's another interesting area of research. And patients will report all types of different pain, head, my lower limbs, my upper body, kidneys, nerves. There's really a lot of different body parts. When we say systemic, we mean it. Those with endometriosis related chronic pelvic pain have more severe pain, greater sexual and social dysfunction than those in unexplained or undiagnosed pain. We do know that proper treatment can improve quality of life. Note, I am not saying cure, but improvement of quality of life is important. When we talk about diagnosis, again, a combination of things like a pelvic exam or a physical exam, lab tests, diagnostic imaging studies, these can help rule out other concerns that are not endometriosis related. And they're certainly very, very helpful for pre-surgical planning. Things like MRI when we're planning a surgery can be very, very helpful. But they have very poor sensitivity and specificity. So that means that absence of evidence is not evidence of absence. You cannot take medication and have your response confirm your diagnosis. So anything less than a surgical confirmation is really just suspect. Now, if the patient chooses to go with that, that is their right. They can do that. They can try a course of oral contraceptives or other medications based on a supposition of endometriosis. Certainly that's an option. Others would like, substantiated confirmation and surgical treatment of the disease. Unfortunately, now 2021, still diagnostic delays are outrageous. We know that awareness is very, very poor, not just among the public and employers, but also among healthcare professionals as well. We really need to ramp up efforts to instruct and train and better educate medical staff so that they have the sufficient knowledge and the skills needed to adequately address someone who comes in with potential endometriosis or confirmed endometriosis. A lot of times we should be looking into referring out. You've heard me say it, when in doubt, refer them out. If you are not capable of treating or diagnosing endometriosis, you should send that patient to someone who is. And that's not just pie in the sky thinking. Data shows that when we talk about doctors who know, quote unquote, endometriosis, 77% of general practitioners indicated that they needed more education about the disease. Only 25% in another study felt that they knew enough about endometriosis to treat the patients in their routine practice. Beyond that, 82% of gynecologists, who are the primary treaters and diagnosers of endometriosis, felt that they couldn't perform or were not comfortable performing advanced lap surgery. So we really need to step up those efforts. Patient frustration is very high as a result. I know I don't need to tell anybody here that. And late diagnosis is very common, and more so even with extrapelvic. If you've got diaphragmatic or thoracic or sciatic disease, the average delay in diagnosis now, 2021, still hovers between 6 to 12 years. We have to do better. I found this this quote in Forbes a couple of months ago, just to really be so telling and just nailing it on the head. Alice Brosser wrote, "You could fly to the moon 456 times before getting an endometriosis diagnosis." And that just, that's endometriosis in a nutshell right there. Management, I'm not going to go too deep, stay pretty topical because we could have a whole another hour on management strategies. There is no prevention for endometriosis. There is no demonstrated universal cure. This is a very multifaceted disease, often chronic. Again, we stress that multidisciplinary team approach for long-term management. Unfortunately, myself, and I'm sure everyone in this room right now, has gone through repeated interventions because you didn't feel better after the previous ones. I myself had 22 surgeries and 4 rounds of GnRH analogs and didn't feel better until my own multidisciplinary excision. So, that's a very common theme. And you've got to address the secondary pain generators. There are comorbidities that are often present with endometriosis, like we talked about, fibroids, painful bladder syndrome or interstitial cystitis, IBS, rarely certain malignancies. These things also need to be addressed when we're treating endometriosis. You can't just treat the lesion and expect the patient to just be 100%. You really need to take an integrative approach. And one size does not fit all. That means patients don't react to treatments in the same way all the time, and all surgeons are not equal. So you really want to find a true specialist if you can, or someone who is going to work with you to try the multitude of treatments and things that might help you. Pelvic floor therapy can be invaluable. There are many, many adjuncts, alternative therapies, a nutritional approach, cognitive behavioral support. If you feel up to it, exercise can be helpful, pain management, and of course, support. Finding others who can help you along that journey can just be so invaluable. And it's not just about the uterus. This is one of my favorite sayings, stop talking about endometriosis as a menstrual disease, as Dr. Kara Jones said a few years ago. It has resulted in its normalization to the point of invisibility. And that's correct. We talk about endometriosis being a disease of quote unquote the uterus, even though it's outside the uterus. And we talk about painful periods. In fact, there's a huge, substantial morbidity and a high burden on our whole well-being, physical, sexual, reproductive, emotional, our relationships, our schooling, ability to choose a career of our choice in some cases. So it's way, way bigger than just the uterus. And it affects not just the individual. It also affects those around us, the caregivers. More often than not, it's a family member. And unfortunately, a lot of patients with endometriosis, we feel like burdens. So there's a whole dynamic there. And again, stressing diseases outside the uterus. It has been found everywhere, including the spleen, even in some rare male. So it's not just bad periods or killer cramps, and it's not about the uterus. And this is a tremendously costly disease. Recent studies put the annual direct and indirect costs in the United States at almost $70 billion. Those costs increase based on the length of time the patient has been diagnosed, whether or not they have actual pain and infertility, and the severity of their disease. We know that it costs almost 3 times more than non-endometriosis controls during 1 year of treatment of an endometriosis patient. And loss of productivity and presenteeism, this is a real thing. Almost 75% of patients with endometriosis report having at least 8 symptoms that interfere with their everyday life. And in the workforce, that's an average of 11 hours per patient per week. And of course, we know, and I'm sure everyone here can relate, endometriosis is related to increased sick leave, we'll go to work sick, and then we'll use compensatory mechanisms to try to make up for that. People shouldn't be using or shouldn't have to use vacation days for endometriosis pain. So, and again, as I had mentioned, there's some consideration given to working in one's desired profession, because they're considering to themselves, am I going to be able to do this, knowing that I'm going to have maybe increased days off, or I'm not going to be able to report to work that day. And at the end of the day, this is a more costly public health problem than migraines or Crohn's disease. These are more commonly understood, or at least talked about, diseases, diabetes, Crohn's, rheumatoid arthritis, but yet endometriosis gets less attention. And disparities, this is real. This is real impact on real people's lives. In terms of funding disparities, we know that the NIH applies most of their resources to those diseases affecting primarily cis males, and that is done at the expense of those affecting women. And of course, there is a racial bias. We know that the BIPOC population is less likely to be diagnosed in a timely manner, and disproportionate use on the socioeconomic front. If you are in the private sector, you are going to have more access to care versus the public sector. And we know from studies that those in the public sector are 3.5 times less likely to get laparoscopic surgery, almost 3 times more likely to be given narcotics as pain relief. And in the one study referenced here, they were the only ones that were using the ER. So there are a lot of disparities. I'm just touching on some of the most important. A lot of our under-resourced populations deserve to really be looked into. Adolescents, often told you're too young to have the disease. In fact, most of them have symptoms like me, and I'm sure many of you, even before their first period, and they later go on to be diagnosed with endometriosis, but by that time, the disease may have become very destructive and impact their health and fertility and future well-being. Again, harkening back to the racial bias, because this is very important. There's this enduring narrative that endometriosis can only affect, rich white women, which is ridiculous and absurd. And that leads to lower diagnostic rates among the BIPOC population. Black women are undergoing more hysterectomies with higher complications, and the route of hysterectomy, such as minimally invasive versus more invasive or open surgery, which is ridiculous. Native American women, less likely to have private insurance and access to specialty care. Even when they did, they reported less reduction of pain after treatment. So we really need to think outside that box and make sure that everyone is represented in this disease. Same for gender and sexual diversity. Too often there are, too many assumptions made about who endometriosis affects and what that patient is supposed to look like. Doctors should be giving information, the same information to all, and not making mistaken assumptions about a patient's sexuality or their reproductive health goals or anything like that. You should be treating the whole patient. And it's no secret that most of the barriers at the healthcare level have been there for quite some time, and we continue to push that boulder uphill. Lack of endo specialists. Some folks put the number between 200 and 300 worldwide. There's 176 to 200 million of us. So, there's a shortage there. In other recent studies, the physicians indicated they had a lack of preparedness. And wanted more training in chronic pelvic pain and endometriosis. Financial barriers, we know all about that. This is such a financially toxic disease. Getting to those specialists can be almost impossible for many people. Once you get to the doctor, maybe you got your diagnosis, but you're still being dismissed, you're still being trivialized, you're still having your pain normalized. And this was shown in quite a few studies. And one of these studies included some quotes by some of the nurses that they had interviewed, and it really resonated with me. I hope my son won't run into a girl like that. I just thought, you need to find a new job. So because of all of these things, advocacy does matter, and hope alone is not a plan, to borrow, John Finnegan's line there. So digging into to the advocacy front, what is necessary to advocate? You need education, training, skills, credentialing. You must have an absolutely solid ethical base, a sense of inclusivity, obviously professionalism, be innovative, thinking outside the box, respecting the patient's preferences and needs based on their life and their culture. Of course, communication and organization, research knowledge and analytical skills, and the most important one of all, empathy and compassion. Now, on the professional side of advocacy, there are some core competencies, which I will just take you through. You need to have, required continuing education hours every year to maintain board certification. You need to be able to conduct research. You need to look at detailed medical information and help the patient understand that and clear up any confusion for them. This is not a sort of an arbitrary or casual activity. These are required competencies. You must have a dedication to improving public health literacy. Health literacy is a huge component of advocacy, because we know that low health literacy is linked to adverse health outcomes, not just in endometriosis, but all of health and well-being. Poor health literacy is linked to decreased use of health services, poor disease outcomes, particularly in the sense of chronic conditions, and an increased risk of hospitalization. Recognizing the need for that patient to seek a second opinion or expert care. That may be just seeing another doctor, that may mean helping them find a clinical trial to participate in. But at the end of the day, you're not making any decisions for anyone. You are helping that patient arrive at a truly informed decision of their own. And you want to help promote them along that. You want them to feel like they have ownership of their treatment plan, and help them get all of their questions answered. So just take a moment, think about, what does advocacy mean to you? What are some ways you advocate for yourself or others? If you're an endo advocate, what are you doing in the endometriosis space? If you're comfortable, put it in the chat, share with everyone, because there are different types of advocacy. And advocacy means different things to different patients. That can be speaking up for yourself at the doctor's, learning more about the healthcare process, really approaching your care with less confusion and better understanding of what's being presented to you as options. Then there's advocacy as agency, which a number of us do. And, this is about the rising tide lifting all the boats. This is about the greater good of the community. These are community advocates that fight stigma. They strive for increased awareness, proper education, policy changes, and things that benefit the collective community. And you can be both. Advocates really do guide a patient's journey. Advocacy is a team sport, as the ARCOG says, and this becomes a collaborative effort with the patient and their doctors and their caregivers. You have to involve their family as well, and anybody else involved in their care. And what you're doing is you're really contributing your knowledge and your expertise to improve that patient's health. You are representing the patient's interests. Advocates have a moral and ethical and, quite frankly, legal obligation to promote equitable access, regardless of someone's age, race, spiritual practice, culture, ethnicity, sexual orientation, gender identity, or immigration status. Advocates serve as the guardians of the patient's rights. And you want to make sure when you're working with your patients that you're understanding and respecting, keyword respect, their preferences and their needs. It's not about what you think, it's about what the patient needs. You can speak on behalf of the patient when or if they require it to bridge communication gaps and coordinate care with others involved in their team. but you are not there as an adversary. You are a conduit to better care for them. And you want to support mobilization of their resources. You make sure that you know what resources that patient needs, or if it's you, do your research to see what you need, and connect to those services that they need. Important, important, important. Advocates and myths and misinformation. Dr. Murthy made this comment a while ago in his annual address. We live in a world where misinformation poses an imminent and insidious threat to our nation's health. Misinformation takes away our freedom to make informed decisions about our health and the health of our loved ones. And that resonated with me because at any given time, we can turn to Google or social media and we will see incorrect information about endometriosis. And that matters. That matters a lot. So increased awareness of endometriosis is vitally important, as Dr. Young says. So we need to work towards those public education programs. If you are a professional, engage proactively with your patients, correct misinformation in a lay-friendly way that they understand. Teach back, each one, teach one, reach one. If you're an association, you help share the most current science-based research and education, and you address the community. If you're an individual, fact check before sharing. The quote that's often attributed to Buddha, but in fact is not actually a statement by Buddha: believe nothing, no matter where you read it or who said it, no matter even if I have said it, unless it agrees with your own reason and common sense. And advocates, there's a subspecialty of advocacy that deals with economic and legal issues. Anyone can self-advocate here or advocate for another if they have the knowledge. Again, some of it is a specialized certification. Some of it is more topical, helping patients understand or helping yourself understand, the costs and the coverage that you have and things of that nature. You can advocate for patients who have received poor care. I know, raise of hands, how many people have been sort of mistreated in a hospital or doctor setting. You can be the liaison to help kind of resolve that issue. On an administrative front, things like MOLST or PULST, which probably doesn't really apply to anybody here, but just in general as in terms of the paperwork, if we have advanced directives, if we have power of attorney, working with disability and FMLA. I mean, of course, again, DNR, hopefully that doesn't really apply to anyone here, but in the general advocacy sense, we can help with the economic and legal side of things. Advocates, by their very nature, are health activists. The goal of health activism is really to challenge the existing relationships that influence aspect of health negatively or impede health promotion. Health activism and policy is really about speaking up about patients' rights, thinking about creating, devising, implementing, and or ending, in some cases, policies that are either helpful or harmful. Bringing endometriosis to the forefront of the political discourse really matters. That is how we connect low resource populations to better health care and reduce disparities. And again, when I say I'm talking about each of us as individuals as well. The overarching goal is really to influence policy in ways that benefit us, whether it's on the research funding front, if it's guiding policy goals, if it's awareness, if it's treatment standards. Nothing about us without us. Clinical research, we work in clinical research as well, either as a study coordinator or a participant, but you can also advocate in the clinical research space by sharing current evidence-based research information to your followers. You can work with clinical trial design organizers to make sure that the quote unquote patients are included, which means that patients are not just study subjects, but they're actually engaged in the study. The goal, of course, pushing for better research direction and more studies. And advocacy, of course, creates safety nets. Connecting to others who understand can really be very validating. Having someone to empower and encourage you along your journey is incredibly valuable. Group settings, can offer you numerous things in terms of support and education, but also peer-to-peer physician referrals, and really take away those feelings of isolation. Nobody understands, what I'm going through, and suddenly I found this group and they get me. That can be so rewarding. So who is an advocate? You have credentialed, which is people like nurses, physicians, hospital workers, professional advocates, social workers, advocacy organizations. You have informal advocates. It's your spouse, it's your relative, it's your friend, it's somebody that you trust. And you. No one knows your body better than you do. Although doctors may spend 15 minutes with you, you live in your body forever. So you have to stand up and be your own advocate. Sitting in the office for 15 minutes is a flash into our experiences with endometriosis, but the impact on our bodies of a lesion of just a few millimeters is seismic. And enduring and existing isn't the same thing as living. We have to work together to find a better way to be living. Advocating for yourself does not mean that you are a difficult person. A good doctor will welcome self-advocacy and participation in your own care. And you may have seen me say this in Endo What? Fight as hard for yourself as you would for someone else. If it was your child or your parent or your loved one, I know that you would be fighting for them, and you matter too. So I want you to fight as hard for yourself as you would for someone else. Knowledge is power. There's our fearless leader. You have to be your own advocate, because again, if not us, then who? You are your own best advocate. And we know that, this is not, again, just some sort of pie in the sky theory or framework. Self-advocacy has actually been shown to increase care satisfaction. And it provides an opportunity for the patient to have a level of control over their disease and their life. So why do we self-advocate? Well, of course, we want to choose the best doctor. We want to be involved in our care, or we want to turn down proposed care. That's important too. The World Health Organization calls patient empowerment a process by which people gain greater control over decisions affecting their health. And we need to be engaged. We need to be engaged and in control of our care, or denial of that care. And it's okay to ask questions. Don't feel like there's such a thing as a stupid question. Ask. You have a right to the knowledge that will inform your journey. And you have an absolute sacred right to truly informed consent. And that means giving all options to the patient and letting them decide for themselves. And we self-advocate to exercise our rights. We have a right to dignity and respect. We have a right to choose or change our doctors. Pre-COVID, we had a right to have someone with us. Some offices will allow it, some still don't right now, but in general, someone to support you at your office visits. You have a right to have the written materials explained to you in a way that you can comprehend. And of course, you have a right to urgent care, 24/7. We self-advocate for value of care. We need to take a look at understanding the cost of our care. Which tests are being ordered, or treatments, and why? What value do they add to my diagnosis and outcomes? Is there a more cost-effective equivalent that I could try that doesn't cost me as much? Study and understand your insurance policy. What's covered, what's not? What is the appeals process? Will your doctor help you with the peer-to-peer or appeals so that you can get your treatments covered? If you are underinsured or uninsured, or if the physician is out of network, do they work with patients? Will they offer self-paid discounts, sliding scale, things of that nature? In terms of medical billing after the fact, look at those bills. Look for errors. The system is not perfect. You could be overbilled. Look at costs that are beyond reasonable and customary for your state, and look at fraud. It happens. You have a right to get those charges fixed. You have a right to undergo appeals, and you have a right to negotiate to decrease your out-of-pocket responsibility. Self-advocating at school or work. it's a little bit flexible, so you'll need to check with your own HR, but generally, employers with 15 or more employees are usually required to provide reasonable accommodations. Now, again, that's a blanket statement. You'll need to check with your own. You are entitled to FMLA leave often after your surgery or if you're sick for the long term. Talk to your HR, your manager, or whomever at your job who might be able to assist you with things like flexible schedules, working remotely, things like accessibility. That could mean preferred parking, that could mean job sharing, even a new chair. I know it sounds silly, but guess what? If you have pelvic pain, the chair matters. If you're in school, talk to your administrators, talk to your teachers, work with them to see what options you have. You can work together to find the best accommodations for yourself. And this is a little busy, so I'm going to spend a little bit of time here. When we talk about the Beltway, we are talking about the public and political aspect of the disease. And endometriosis is absolutely a public health issue. And it has enormous economic and social impact. And I always say, endometriosis, chronic pelvic pain, gynecopathologies, they should be receiving as much public policy focus as procreative health, and they don't. And we need to change that. So we work in the Beltway with legislators and local leaders, federal leaders, really to improve upon the programs that are there and to eliminate policies that aren't working, reducing stigma, promoting health equity, insurance coverage, accessibility to care, accommodations, flexibility, public disease education, a public campaign so that we know what's going on with endometriosis and how we might think that we have it and when to seek care. Legislative appropriations, that's talking about funding for research, the Congressional Directed Medical Research Program of the Department of Defense, that's a pretty robust funding program, but it's not enough. And the NIH increase is not enough. We need more. And I always say it, the system isn't broken. They built it that way. But your legislators are supposed to work for you. So contact them. Don't be shy. Don't be afraid. Share your stories, share statistics about endometriosis. Do an action alert to your local officials or any of your elected officials. Urge them to take action and pay attention to endometriosis. Meet your representatives, whether by Zoom or quote unquote email. Send them endometriosis information. Light that building. Sometimes getting the building lit leads to something tangible down the road in terms of a public action, whether it's a resolution or it's an educational campaign. These things all let you put your claws in and take hold so that you can make a difference down the road. Go to those town halls, even if they're by Zoom now. Go to the public forums. Ask your officials why endometriosis isn't considered a national health crisis. And be persistent, be realistic, be persistent. You will find that for the most part, you will get bipartisan support from both sides of the aisle on aspects of endometriosis. On a deeper level, working in the Beltway, that's making sure that acts that are already being reviewed, whether it's Affordable Care Act or things of that nature, we want to make sure that endometriosis is being included. And you can self-advocate at home. Self-care, self-care, self-care. Leisure should be taken seriously as a vehicle for enhancing well-being and adaptation to life with long-term illness. That means when you need to rest, you should. Nutrition plays a role in endometriosis symptom exacerbation. So you want to avoid toxins of all kinds, environmental, situational, and people. Find a support group. There's a lot of psychological and educational benefits in terms of self-help and mutual aid with support groups. You can do it online, so there's no real, mobility or transportation barrier there. Of course, there are some drawbacks to some groups. Sometimes they are unbeknownst to the members. They are run by commercial interests. And then other groups have a lot of, either deception or discord, which is not healthy for anybody. Learn, ask questions of qualified resources, learn about the disease and your situation using authoritative educational sources, and then educate your family and those around you. Fight the stigma. An easy way to do that is to drop the slang. I mean, I know it sounds so simple, but it can make a difference in terms of period shaming and talking about bowel problems and, bladder problems with endometriosis. And you have the right to expect dignity and respect in all settings at all times. Demand it. When we talk about the bench level, again, we're talking about the research and the training aspect of endometriosis. It is no secret, and I am not shy to tell you that many of the studies on endometriosis lack translational benefit. Many of them are industry sponsored. And it is really advocate-driven research that has led to seats at the table for the funding review process. We have a say in what gets funded to some extent. So you definitely want to try to participate or promote efforts for increased funding and facilitation of more meaningful research. Things that is, studies that are really looking into the relationship to cancer, its relationship to chronic pelvic pain, new and novel ways to diagnose and treat it, etc. You can participate in clinical trials. You can also sit on different boards in terms of oversight of those trials, whether it's in a watchdog role or contributing your ideas on how that trial might be designed. And you want to really encourage more focus on patient-centric goals. Unfortunately, in academia, there's a publish or die mentality a lot of the time. So you'll see a lot of the same people churning out a lot of the same work. We want to elevate that. So we do that by working in partnership. We sit in community-based initiatives. We talk about treatment plans. We talk about evidence-based options. And we really, at the end of the day, are ensuring that health-related quality of life issues are being incorporated at every aspect of the research journey. If you're thinking about joining, a patient or consumer representation role, we know that what research collaborators are looking for are people who, yes, understand research and protocols and have the scientific medical background and knowledge. That helps. Grant reviewing helps. National advocacy experience does help. But really what they want is someone who is thoughtful and engaged, someone who's going to share with them, yes, their experience, but also serve as a voice of the patient. What they're not looking for are people who can't communicate, somebody who's an idea dictator, which basically means that, it's your vision and no one else's. And someone who is really not there to listen, but more to serve in an argumentative role. And no one understands better than me how easy it is to become argumentative, but you kind of have to check yourself and say, okay, I'm going to be open-minded. And that is how discourse happens. People talk, they collaborate, and we come up with new answers. At the doctor's office, again, you have the right to have your any materials explained to you in a way that you understand. When choosing your doctor, look into your reviews and peer experiences. There is a little phenomenon going on, particularly in endometriosis right now, called astroturfing, where the reviews are fake. You want to avoid that. Check into their medical legal background. Do they have lawsuits? What was it about? Industry ties, super important. Is their philosophy or their treatment offering tied to industry in any way? And you can do that at openpaymentsdata.com. Or you can also go to ProPublica. They're a little less timely than Open Payments. Get a second opinion and a third and a fourth if you need to. Know that you have a right to your records. You have a right to correct any misinformation that you see in them. Keep a copy for yourself. Sitting in the doctor's office, talk to them before you get undressed and before you have a pelvic exam. Nobody can do anything without your consent, and you can decline any part of the exam that you want. If you have something, a traumatic history, something that's making you feel uncomfortable or unsafe, let them know that. Because again, you're talking about bodily agency, and you are in charge of your own care, and no one can make you do anything you don't want. Ask questions, research their answers, and then ask more questions. Journaling can be so helpful, if not cathartic. Talk about your symptoms, when they began, how often they occur, what makes them better or worse, a little medical history, who's on your healthcare team, what treatments have you decided or have you tried, what have you decided against, things like that. Patient assistance programs. Industry is only far too happy to help patients get on their drugs. If you go to medicineassistancetool.org, you can find a list of different pharma and industry companies that can help from a financial perspective. And at the end of the day, you know your body best. If you are dismissed or invalidated, find a new doctor. Advocacy, especially self-advocacy, means asking questions. When you're choosing your doctor or continuing care with your doctor, ask yourself, are they unfamiliar with endometriosis? That means they don't typically treat the disease and really never heard of it. Are they aware of endometriosis but inaccurately informed? And that seems to be the most popular category, unfortunately, in OBGYN. They know about it, but they're putting out bad information. Are they aware of endometriosis, but really kind of not very well informed? Or are they accurately informed and routinely engaged in endometriosis? This is someone who treats the disease all the time, keeps up on evidence-based medicine and modern concepts, understands, that this is a multidisciplinary disease. They're going to help you find some answers. Think about who else is involved in your care. What do they bring to your team? What is their role? Is it a nurse? Is it a surgical assistant? You want to know who's being involved. Insist on the 4 C's, or what is it, 5 C's, comprehensive, coordinated, continuous, compassionate care, 5 C's. And think about it. Ask yourself, does your doctor listen to understand you, or do they just listen to reply? And there is a difference. This is on our website, so you don't, need to write this down the next 3 seconds. But just to give you an example of some kinds of questions that you can ask when you're interviewing a new doctor, or even if you just want to check up on your existing doctor. How many cases do you treat annually? How do you treat them? Medically, surgically, both? What are the pros? What are the cons? Where did you do your fellowship training? What tests do I need in advance of surgery, and why? Do you have a multidisciplinary team in your OR to remove all the disease in one encounter? For example, if you're a lung patient, we're going to have our cardiothoracic surgeon there. How can I best prepare for my surgery? Should I be stopping supplements? Is there a special diet I should follow? Are you sending what you find to pathology so I know what you took out of my body? What do you recommend post-surgically? Pelvic floor therapy, things like that. When can I go back to work? When can I have sex? What's your post-surgical pain management protocol? Things like that. And again, this is on our website. And anything that you see here today that you want more information on, I'm very, very happy to send you. So please don't think you need to start writing these down. Self-advocacy means choosing the best care for you. It means getting truly informed consent, and it means you're deciding, not your doctor. Do nothing is an option. No one can force you into any kind of treatment. There's no quid pro quo. If you take this drug, I'll do this surgery. It doesn't work that way. Do nothing is an option. When you're refusing a treatment or choosing, is the doctor opposed, which means that they're committed against your choice wholly. Are they neutral? They have no opinion. Are they a low supporter? They don't really oppose you, but they're not really actively supporting you in your care either. Or are they a high supporter? This is someone that's actively working with you to find answers to help you find relief. More often than not, they're also somebody who is speaking out on your behalf out in the community and with other doctors, someone who is a visible and a vocal champion. And if at the end of the day, you are forced to obtain your own referral to a specialist, make sure that your request is supported by evidence. Make sure that it's brief, clear, and concise. That request is not necessarily the time to pull in your whole narrative, but you want to show evidence why I've tried to get care here. I haven't been able to. This is what I'm suffering. This is why I want care. And here's the evidence to support it. And this is my favorite slide. Self-advocacy is standing up for yourself. This mug shows up in my timeline on every social media feed, and I hate it because it's so arrogant and so condescending. Please do not confuse your medical degree with my lived experience, okay? But to that end, I mean, I'm being snarky, but to that end, remember, it is a partnership. The days of paternalistic medicine are over. This is a partnership. This is shared decision-making. At the end of the day, you live in your body. You ultimately are the one who decides for yourself. So we ask again, is endometriosis advocacy important? Yes, it is. It breaks the cycle, pun intended. We know endometriosis is a priority public health platform. It affects hundreds of millions of people at billions of dollars in costs. Advocacy is a critical part of making strides towards improvements. And we do that with collaboration between patient and all relevant stakeholders. Advocacy is agency, which we talked about before, working within the system and the community to meet the needs of everyone. Again, the rising tide lifts all the boats. We want to strive towards facilitating widespread dissemination and deployment of public education programs, Fem Truth Youth, the Endo What Nurses Kit. This helps inform the public on symptoms, when, where, how to obtain help, because reducing diagnostic delay matters. And these can be deployed not only in schools, but at work, throughout the public setting, with legislators, in kinship settings, and anywhere in your community. Advocacy helps us really survey the adequacy of existing care, which is so poor across the board for the most part. But it also helps then create policies which can strive towards a better standardized care, multidisciplinary approach, helps incentivize and improve training, which again relates directly to patient care, and it promotes tertiary prevention strategies. That means while there's no definitive prevention or any prevention for endometriosis, tertiary prevention helps reduce the impact on those of us already affected, finding ways to help that patient cope better and live better in spite of the disease. And we need to fund better, more meaningful research. And we do that again, in the Beltway. We strive for policies that reduce these gaps. Things like working on the revised coding, 58662 means endometriosis destroyed by any means. It has no variation between excision, full duration, cauterization, or ablation. So when your doctor is excising for 6 hours, they're going to get paid the same $300 that someone who just burned your pelvic sidewall is getting. So we need to work on the coding, and that is a work in progress. Formally recognizing the subspecialty of an endometriosis specialist, that will help. And that's something else that we strive for. And at the end of the day, you really want to reduce the bias and the disparities at every step of the patient's journey. Inclusion and engagement and access matters to everyone. So the power of patient advocacy. Advocacy changes lives, especially our own. I know my body best. I have the right to make decisions about my care. I have the only right to make decisions about my care. I advocate by speaking up for others to make sure my rights and choices are respected. I voice my concerns not in an adversarial way, but in a way that's going to encourage discourse and dialogue and collaboration. I advocate to improve access-related barriers and improve knowledge for myself and others, because I know that health literacy is linked to timely diagnosis and better care. And at all times, I'm the leader of my treatment team. Not only does that help me choose the best and most effective treatments for me, but it also prevents, at least reduces or prevents harm, overcharging, overtesting. And this is by no means, you can't wrap this up in a little bowl and say, here, this is advocacy. Progress is not perfection. You're going to fail. You're going to feel like you can't do it one day or 2 days or a week. And that is okay. It's okay to rest and try again tomorrow. Rome was not built in a day. I've been at this for 30 years and, I can measure the progress incrementally. So don't give up. And I thought this really resonated, and hopefully it will with you as well. The final stage of healing is using what happens to you to help other people. And that is why I do what I do. And that is why I started doing what I do, in the late 80s, early 90s, because I really felt helpless and alone and uninformed on my own journey. And I went through a lot of mistreatment and a lot of gaslighting. And I want to make sure that nobody else can do that. So, if any of these pearls help you along your journey, then I have been successful. Shameless self plug. This is completely free. You can download all 1,800 pages or whatever it is from the internet. And again, please don't feel like you have to write this down. I will send you the link if you email me. And any other information that you need, you can access the endo chapter there. I'm very, very happy to say that over 15,000 people have read it in the last 9 months, which means endometriosis education is getting out there. Just some resources. And again, email me. I'm happy to send them to you. If you don't see yourself on here and you have a resource, it's not because I'm a terrible person. I just literally forgot, and I'm so sorry. Some groups and some organizations that have been really helpful, not just in my journey, but are doing really strong work. And that is my email address. If you don't know it already, heather@centerforendo.com. You can get in touch with me. I will send you whatever information you need, resources, links you saw today. I'm happy to send them to you. And I think we will take questions. And I will stop sharing. And there we go. So thank you very much. I know that was super long, but this is a really important topic. And I feel like, there's not enough hours in the day to talk about it all. So hopefully you've gleaned some useful pearls out of it, and maybe you can help yourself or someone else along your journey. So I thank you.
Thank you so much, Heather. That was such an amazing talk. Actually, Etney sent me this comment, so I'm just going to read it because I think she said it better than I could. She said, "This is one of the most comprehensive tea talks we've ever had. I feel we can guide people to this recording when they are new to endo or trying to help a family member understand what endo is and why it should be taken seriously."
That's what it's about.
Exactly. So thank you so much for doing this talk for us. We're going to go ahead and open it up for questions. If you have questions, you can go ahead and post them in chat. You can send them to me and I will go ahead and read them. Let's see. We had one question sent to me during the talk. Let me find it. So you were talking about keeping abreast of current evidence-based research and sharing those findings. Someone asked, how do you know what articles are legitimate or not? How do you know what is the good research that you should be sharing?
There's the rub, right? Okay, so you can go to PubMed, and most articles have a lay abstract or lay summary for those who are obviously not everybody can work in research and doesn't understand, articles this long. PubMed will have a lay summary. Okay. Now, I'm going to get some flack for this, but I don't really care. Check the disclosures. Scroll to the bottom of the article, check the disclosures. Who funded that article? If a certain pharmaceutical company funded it and the article talks about how we don't need surgical diagnosis, we can just give drugs, I'm inclined not to share that. But I think that most patients are so educated and have such an innate sense of this disease. And like the quote says, if it doesn't make sense to you, it's probably not accurate. But also you want to see how many articles cited that article. So in other words, just take any reference from my citation list. How many other people shared that? Because that's how the information is sort of propagated. If Professor Mike Armour wrote an article talking about how much endometriosis costs and how big the impact is, and I see that 50 other papers shared that, and it agrees with my own sense of the disease, I'm going to share that. So use your judgment, but check those disclosures at the bottom, because if that article was written in the service of someone else industry and not patient well-being or progress, it's not something I'm inclined to share. And you can ask, go to our center, go to any of the endo centers, ask them what they think. Is there, is this factual? Is this, what is this based on? You can ask.
Great. Thank you so much. And one thing that I've definitely done several times is, one of the great things about the Center for Endocare's website is that y'all have citations peppered throughout the informative pages. And so time and again, I have actually gone and clicked on those citations because I'm like, there's something that I want to say and I know it's right, but I don't have the evidence to back it up. So time and again, I have definitely gone to the CEC's website.
That's what it's about. And honestly, we do keep abreast of that. And if something changes, we're going to update that, and we're going to, change the link, the citation link. You need to be current. If we weren't keeping current, we would all just be sharing John Sampson's 1927 article, and that wouldn't get us anywhere. So, yeah. I hope that helps a little.
Definitely. We have one person who asked, is there truth endometriosis can be suppressed by eating plant-based?
There is not a lot of evidence on phytonutrients and endometriosis. I approach the diet nutrition thing this way. If you feel better, eat it. Jessica Murnane has some great books, Know Your Endo, and I think it's One Part Plant. I hope I'm right. She's got some great information on endometriosis and diet. There is emerging research on diet in the sense of FODMAP, gluten, and things like that, but there's no eat this plant or only eat vegan or only eat this. There's not enough evidence-based medicine to make any kind of assumptions about it. So, we usually say, go for low inflammatory, organic if you can. It's not necessary, but it's nice if you can. Low inflammation diet. Red meat doesn't seem to agree with anybody with endo, whether they like it or not. Bringing plants into the diet can only be helpful. Is there a specific plant or supplement that will cure all the endo? No. Can you use diet to modify your symptoms? 1,000%. What that looks like to you may be different than somebody else. So it's a lot of trial by error and a lot of, see as you go. For me, personally for me, anything that is processed hurts me terribly. Even now, 25 years post-excision, I try to do more leafy greens, deep greens, veggies, things like that, lean proteins, no red meat. I haven't found that any one particular supplement or food has done much, and the evidence hasn't either. So trial by error. Exactly. If it makes you feel good, do it.
Another person who I think is, just to add on to what you're saying, Jessica Drummond is another good person to follow. Yes. And, she's been leaning more towards, don't so much eliminate things. Don't focus on eliminating things. Focus on adding nutrients. Focus on really filling your diet with things that are good for you, that make you feel good, and stress less about the things that you can't eat.
Right. No, absolutely. Yeah. Jessica is fantastic. Yeah.
Another question that we had that came to me was, are there research studies for the endo community that we should be aware of or following and participating in? Do you know of anything that's going on right now? I know that there was something that Extra Pelvic Not Rare was participating in. I'm not sure if that's still going on though.
Yeah, that's Dr. Bingham's study that she's conducting. she's here. I don't know if she wants to put her link to her study in the chat, if that can be done. That's a study being conducted. You know, there's always emerging research, things like, you know, targeting genes. The problem is there's no current study that's come out and said, yo, Eureka, we found all the answers. Let's promote this now. There is a lot of promise and a lot of hope, and things that we keep abreast of that we still don't really have the end result of yet. Things like the recent gene target. That has a lot of promise. You know, more research sort of on the imaging side, which is unfortunately so operator dependent. And there are two camps. There is, no, you can't use imaging. Yes, you can only use and should only ever use imaging. And somewhere in the middle is a patient being torn in half. So, you know, we follow more things like that in terms of diagnostics. Emerging treatments, I wouldn't call it emerging treatments because they're not new. Sorry, AbbVie. But I think that there's, you know, a better sense of many researchers now really looking into pathophysiology, how we can turn off genes before they start, which is, wow, critical. But there's nothing right now that I would say, oh my God, everybody run out and share this. You know, just try to keep abreast of it and then follow it. I mean, there are studies coming to fruition now that we've been following for 15 years. And it's interesting. Sometimes they start out as one thing and, you know, they have suppositions about, you know, what their goal of the study is going to be and what their hypothesis is. At the end of the study, it was like, oh no, that didn't happen. So I think just keep abreast, you know, set a Google alert. Hit up PubMed, get the table of contents. They'll be sent to your email address. And that way you can kind of keep abreast. I look to, you know, the community organizations and the researchers and centers like ours. You know, we have an obligation to put that information out there. So I say stay tuned to sites like ours and yours and see what's what.
Great. Thank you so much. Yeah, definitely, you know, keep up with some of the great advocacy and education websites, social media accounts. So the Center for Endo Care, the Endo Summit, Endometriosis Foundation of Houston. There are lots of different pages that you can follow, that some of the ones Heather listed. We have some on our website as well, efhou.org. Different resources that you can follow. And a lot of times we all are posting pertinent information such as research studies that you can participate in. Okay, we have a moment of controversy. I
was here.
Someone wants to know, do you have any thoughts on the situation coming out about Amy Schumer and hysterectomy, and some of the misinformation that's been sort of floating around this recent event?
Well, I will say this. Good luck to Amy. You know what? She is an endo person. I want nothing but her total healing. Go, Amy. Celebrities and endometriosis, to begin with, can be problematic and have been problematic. I mean, if you look at another similar situation where the person said, Lupron is the same as surgery. That went around the world before the truth could even get its pants on to correct it. So, you know, it can be problematic. With that said, they have as much right to share their story as anybody else. If it brings awareness, that's great. Hysterectomy and endometriosis. Hysterectomy has a place in endometriosis. I have had a hysterectomy. I also had adenomyosis, which is really what a hysterectomy will cure. It does not cure endometriosis. Does that mean no one with endometriosis should have the choice of a hysterectomy? Absolutely not. If that's what they and their physician decide, and they have made a fully informed decision about that, more power to them. Will a hysterectomy cure endometriosis? No. No. You saw in my slides, there's a 15% chance of pain worsening post-hysterectomy. And the same holds true for oophorectomy. Simply taking out the ovaries is not some surefire way of preventing endometriosis symptoms from arising. So what I would look into is, all right, I've had a hysterectomy. Was all of my disease also excised? Were my secondary pain generators addressed, such as pelvic floor dysfunction, adenomyosis, fibroids, adhesions? Those are the kinds of things that we look at in terms of hysterectomy for a treatment. The notion that retrograde menstruation is the cause of endometriosis is 101 years old. If retrograde menstruation was the cause of endometriosis, 90% of people with periods would have endometriosis instead of 10%. The tissue would be identical instead of slightly resembling. Hysterectomy would be a cure. It is not. So all of these things can still exist in the same space as hysterectomy is an option. Retrograde menstruation, I don't know why. I don't know why this still continues to be the focus for so many people. We have so many better ideas and theories and concepts about endometriosis in terms of, being born with it, having certain triggers, stem cells, so important. Retrograde, if at all, plays a very, very small role. I'm not a supporter of retrograde. And I'm not a supporter of hysterectomy as a cure. I am a supporter of people with endometriosis doing whatever is necessary to make themselves feel better and improve their quality of life. It's also my literal job to make sure that they're educated enough to make an informed decision about that. I hope that addresses it.
Thank you. It does. Yeah. And I think one of the biggest problems with that is that people are not given the information to make that informed decision regarding a hysterectomy. If you know the risks, the benefits, know that this is not a cure and you still want to have a hysterectomy, that is absolutely your right. And I hope that your doctor supports you in that.
Absolutely.
But I'm so tired of people being bullied into surgeries that are not going to help them and that are false hope.
Absolutely. And the thing about surgery too, in general, not just hysterectomy, but if surgery hasn't worked, you need to look at why. So who did the surgery? Because it is the singer, not the song. How did they do that surgery? Did they excise or did they burn and leave a shit ton of disease behind? And you have to look at the big picture of that patient, because you're not treating a lesion, you're treating a human being. So the idea that, another surgery is going to make a difference isn't always true. Now, if that surgery has been poorly done and you have a belly full of adhesions and endometriosis, yes, a specialist may be able to help you. But the idea that, another surgery is going to be the answer really probably isn't lending to that patient's outcome, whether that's a hysterectomy or not. But again, at the end of the day, it has to agree with your philosophy. You need to be on the same page as your physician. If they believe and are invested in the retrograde theory of menstruation as a cause of endometriosis, and you believe that, that's great. Good for you. And I wish you well. And I hope that, all the relief in the world comes to you. If you are more of the modern concept school of thought, and you believe that excision is a surgical cornerstone, followed by multiple adjuncts and lifestyle interventions post-surgically that will help you long-term manage the disease, that's great too.
Great, thank you so much. Let me see if we have any more questions.
I see what Dana said. Yeah, I hear you, Dana. I hear you. Unfortunately, the thought leaders and the influencers have the most access to the resources and tend to be the loudest voices. And that is why I encourage everyone so much, really to share their story and tell their tale and share if they're comfortable, only if they're comfortable, share your experience, because you know what? Your story is just as important as anybody who's on TV, if not more so. And unfortunately, your struggle is probably going to be harder because I know that I don't have access to the same resources as, someone who's on TV or in the pages of a magazine necessarily. And probably many of you don't either. So it's really important that you don't let the narrative be taken from you. And the bullying, yeah, don't be bullied because someone on Instagram did it,
Mm-hmm. Yeah, and I think one thing that's really tricky in the advocacy sphere is that trying to educate people and say, these are doctors who can help you. These are doctors who know what they're doing, but also not making those people feel like they're being bullied because they're seeing a doctor who isn't this supreme surgeon. So it's a really tricky thing to navigate. And I think that a lot of times it comes from our own trauma seeping out and not wanting other people to experience that same trauma that we as advocates have gone through. And that, so many people with endo have gone through.
100%. A lot of the problems, we went from like 20 years ago, peer-to-peer referrals to a network of folks that could help to it's almost become like a competition cult. Like, well, you need to see my doctor. And I say that as a center of expertise with the leading surgeon in the world. It makes me uncomfortable to see that, well, if you didn't see that specialist, then you obviously aren't sick enough or you don't care. I find that to be so trauma inducing and just so bullying and so wrong. If you can get to specialty care, and I will help you get there if I can, that's fantastic. But the reality is you need someone in your corner who's going to help you manage long term, no matter what that is. That could be a general practitioner. That could be your pelvic floor therapist. That could be your regular OBGYN. That could be whoever. This notion that, you're not trying hard enough. It's just, wow. When did we become that as a community? Right. And I find that truly offensive.
Yeah. Because this disease, isn't like soul sucking enough.
Right.
Right.
Right. I need to be bullied by my peers now. Right. Yeah.
Yeah.
Yeah. Yeah. I don't care who you see, what you believe, what you eat, drink, or smoke, or do for your care. I just want you to get well.
Exactly. I want you to feel better.
If I can help guide that and I can introduce you to options that you never thought of, like, our pelvic floor therapy network, or, like you said, Jessica's book, or anybody, any resource that can help you along the way, there's no end, there's no limit to the type of help that we can offer somebody.
Exactly. All right. So thank you again so much, Heather. This has been such a wonderful talk. If we don't have any more questions, I'm going to go ahead and turn it over to Maria Mamora. Maria is the chairwoman of FU, aka the Endometriosis Foundation of Houston, and we call ourselves FU because that's pretty much the sentiment when it comes to endo. So Maria is going to do a giveaway for us. So for all of you who have stuck around, she's going to announce the winner of our t-shirt giveaway.
All right. And so before I do that, I want to thank you, Heather, so much. I'm sure I speak for so many that you inspire so many of us in this space to strive to provide helpful resources and information, and more importantly, to give us the confidence to be our own advocate. And for those who are very new to our organization, the Endometriosis Endometriosis Foundation of Houston was founded in 2019 by a group of volunteers. There's 6 of us to raise awareness about the disease here in the greater Houston area. So in March of 2020, we were supposed to host our first endometriosis awareness rally. And as you imagine, you know what happened back in March of 2020. So we are giving away what would have been our first rally t-shirt. We can't really see it because I have it on. It's this. Oh, it's in blur, sorry. So we'll be giving one away and a FU bracelet. So the winner for today's giveaway is Sharon West. So Miss Sharon, will you please just, you can private chat me your information, your mailing address, and we'll send that out to you. And for all of our new friends who joined us today, thank you so much. And I hope you continue to follow us. Check out our website, www.efhou.org, and all of our social media. And I hope you join us for more future Tea Talks. And hope you guys have a wonderful day. So thank you so much.
Thank you so much.
Thank you so much for joining us. Been absolutely fantastic. We will, oh, sorry, go ahead.
No, I was just going to I was able to read the chat. I just wanted to give a shout out to everybody who listed what they were doing for advocacy. Whether it's sending one kit a year to somebody, to running a foundation, to helping one patient somewhere, you are all doing it. You are all making a difference. You are making the change. Cindy Sonervo, my dear friend, she gave me a necklace once. She said, be the change you want to see. And I live that. And you are all being the change you want to see. So I just really want to thank you, all of you, for coming, for letting me show up here today and take up all of your time and babble on and on. But really just for what you're all doing, because, it does take a village. So thank you.
Thank you so much. Right. We will be sharing a link when the video is ready. We'll be posting it on our social media. We'll be sharing it to YouTube as well. So just keep following us. Go to the event page and we will post it there as well. So you can have an opportunity to watch again and again. Bye, everyone. Have a good day.